Good morning, everyone. Welcome to the National Hispanic Council on Aging's virtual legislative breakfast. My name is Oscar Ramirez, co-founder of Fulcrum Public Affairs. It's my pleasure to moderate today's virtual event, which is proudly supported by the Better Medicare Alliance, Merck, Pfizer, Pharma, and Novo Nordisk. For over 50 years, NHCOA has worked to improve the lives of Hispanic older adults, their families, and caregivers. Our commitment to our mission has only been emboldened in the face of ongoing health disparities in our communities. NHCOA's legislative breakfast is an opportunity to open a dialogue between legislators and their constituents, enabling citizens to share their stories and experiences while directly discussing legislative priorities with the lawmakers who represent them. Today's legislative breakfast will feature a panel of experts and voices to discuss the barriers that prevent Latinos from accessing healthcare. Some of the topics that will be addressed include health equity, women's health, obesity, COVID-19 treatments, and Medicare Part D, among others. After this event, we will come up with a list of recommendations focused on Latinos for lawmakers to address this legislative session. To begin the virtual event, it is my pleasure to introduce Dr. Yanira Cruz, President and CEO of NHCOA, and one of the nation's foremost advocates and spokespersons for diverse older adults. Welcome, Dr. Cruz.
Thank you, Oscar, and good morning, everyone. It's great to be here. Thanks again to all the panelists for being here as well. And so let's get started. So 2024, this year, will be an important year for the National Hispanic Council on Aging and for US policy. Much of our work, actually the key issues that we focus on for older adults, their families, and their caregivers are expected to be addressed by Congress. And today, we gather to bring specific attention to the issues that impact our health. Within the Hispanic community, we view health as a chief concern among many other areas. We recognize health and wellness to be our greatest asset. And at the National Hispanic Council on Aging, we do our best to ensure that is also reflected in our work every day, with healthcare being a serious priority. We know that a healthy society is a productive society. There's surely much to celebrate. New research and development in health science, technology, and medicine continues to usher us forward to more efficient and knowledgeable practices. Knowledge that is not just informed of a genetic demographic, but with particular attention to Hispanics and Latinos. But we are still far from realizing our vision. We are far from seeing a society whose medicine and healthcare benefit all who need it, and whose treatments are unilaterally informed on the different genetic makeups across the country. There are still obstacles to overcome and eliminate to reach these goals and to eradicate health inequities. And so this morning, we will hear about and discuss public policy solutions that can bring us closer to equitable health and promote good health and practices and behaviors. And so before we move forward, I would like to thank our moderator, Oscar Ramirez, for agreeing to help us with this session, and also our panelists, of course, our sponsors, for making this event possible. Let's make the most of this special opportunity. I hope you enjoy the program. Turn it over to you, Oscar.
Perfect. Thank you, Dr. Cruz. Before starting the panel session, let's do our first poll question. The first question: what do you believe are the main factors contributing to the high rates of obesity among Latinos? And the options are, you can see below: lack of access to lack of access to healthy food options, limited opportunities for physical activity, cultural dietary habits, socioeconomic factors, or other. And please specify in the chart. We'll provide you a minute for you to choose. Please note you can write other options in the chat box, and we'll give you 1 minute to do that. All right, thank you everyone for participating in today's poll. Let's start with our panel session. Oops. Sorry about that. Okay, according to the Centers for Disease Control and Prevention, roughly 45% of Latino adults are obese. Among Latino American women, 78.8% are classified as overweight or obese, compared to 64% of non-Hispanic white women. In 2018, Latino Americans were 1.2 times more likely to be obese than non-Hispanic whites. It is important to highlight that providing access to diverse therapy options is essential to equitable, person-centered care delivery. Let's welcome our first speaker, Dr. Ray Serrano, who currently serves as the National Director of Research and Policy at the League of United Latin American Citizens, LULAC. In this capacity, Dr. Serrano leads a significant expansion of policy-guided research, informing legislation and enhancing LULAC's dedication to serving Latino community. Today, Dr. Serrano will highlight the challenges facing Latinos living with obesity. Welcome, Dr. Serrano.
All right. Thank you for the introduction, and thank you, Dr. Cruz, and everybody from NHCOA for inviting me to come out today. And as Dr. Cruz mentioned today, that this is kind of a follow-up from a previous session that we had on the issue of obesity and social determinants of health. And so I wanted to so when I was kind of thinking about a topic of how to approach this issue, there's so much in the ideology of what it means for Latinos to be facing this issue. I thought about the issue of the concept of the $1 million patient. This issue for me is pretty near and dear to me, and in my presentation I'll go over some of the things why it's so personalized for me. So first, next slide. As Mr. Oscar mentioned, the issue of obesity by race and ethnicity is an issue that largely falls into Black and Brown communities. We see of the population for African Americans, about half, about 49.6% of African Americans are considered obese, and then about almost 45% of Latinos. And really, it's kind of both a Latino male and female kind of issue. What's really more concerning is the rise of childhood obesity. So we're seeing obesity rates among Latino children, particularly for Latinos, being highest out of any racial and ethnic group at 21.9%. Next slide. Next slide. Oh, here we go. Sorry. No. Go back to the previous slide. Sorry. There we go. So as I mentioned, the issue of obesity for me, it's I'm going to get a little personal here. So when I think of the etiology of obesity, it is an etiology that is very complex, and so there's a lot of culprits in this, and we try to go in the discovery phase of who done it and what caused it. So there's a genetic predisposition. There's obviously dietary factors, socioeconomic factors. Latinos, I say sometimes Latinos have the prize of having the kind of the worst. We're in terms of we're least likely on the metrics, at least likely to have a college education, least likely to have a high school diploma. We have language barriers, we have cultural barriers, we have socioeconomic barriers. There's body dynamics, and then compound that with the kind of the environments that we're in. You have a very big recipe for a lot of challenges, and so in the case of my situation, so my mom was single mom. She raised my sister and I. My sister's now a medical doctor, myself a PhD, 4 older brothers, and she was one of the hardest working people I knew. She worked 2 jobs, 16-hour days, every day from 6 in the morning to 2 p.m. for one job, come back home, shower, get ready for the next job from 3 p.m. to 11 p.m. every single day. But my mom's health, by the time she was in her mid-50s to late 50s, was kind of declining fast. Obesity was becoming a bigger problem for to the point where by the time she was in her late 50s, she was around 535 pounds. And with that became, next slide, became a lot of the other challenges that we saw with typical for a lot of folks who have who are obese. You have issues of heart disease, you have high blood pressure, diabetes, depression is not included in this, but sleep apnea, high cholesterol, cancers. Mom she didn't have cancer, but she had almost all the other ones, in addition to stuff like, knee replacements. So what I was looking at, so like mom, who was a lady who was very frugal, who worked 2 jobs, in many ways was kind of ashamed of the stigma of dealing with this. And I recall a time I met with one of her providers for myself. It was one of her providers, and he recognized my last name, Serrano, and he said, "Are you related to Maria?" And I said, "Yeah." He's like, "Your mother's really, really out of shape, and she's really obese. I don't give her longer than a year to live." And I was around 21 or 22 at the time, so I just remember dealing with that, and I just remember the stigma of how, I'm like, I don't think this doctor gets it. I don't think he quite understands what it means for her. She's trying hard. She just works extremely hard. It's hard for her to kind of have a balanced meal when she's not really being able to cook because she's working 2 jobs. And times are tough. So obviously food banks and food stamps and stuff, it's tough to. I don't think we weren't on SNAP benefits, but we're like food banks. I mean, to make ends meet. And it wasn't the most healthy item. So what I wanted to highlight in this slide here, I wanted to show the actual cost of treatment. So if you look at diabetics, spend about $19,000, almost $20,000 in medical expenses more per year. About $12,000 is attributed to diabetes. Hypertension, for blood pressure management, we're seeing about $24,000 per quality, so quality adjusted life years versus the standard. And depression is just an example. In one's lifetime, the cost of that is $1.5 million for depression per person. So you look at the cost again. Somebody who, like my mom, for example, is simply easily becomes the $1 million patient. Next slide. To make matters worse, there's a lot of other factors that are happening right now. I don't know if folks have followed in the news, but there's stuff that is happening. Obviously, there's the ongoing challenges of food deserts. As prices go higher, people can't afford very much. The profit margins go down. Stores start closing, so you start seeing signs like this, where this Aldi in this neighborhood is closed permanently. So again, giving rise to a food desert. Also, in certain poorer working class areas, we're starting to see a lot of rise of fast food swamps. It's an issue of how our ability to kind of push back on development efforts of developing kind of fast food areas. They become very saturated in certain working class areas, so that becomes kind of the food options that we have. Add to that food stamp benefits, and so I'm just looking at the neighboring state. I live here in DC, the neighboring state of Maryland. The SNAP benefits with the cutbacks recently have got between $6 and $8 a day. And just to give you a full comparison, I sometimes walk over a couple blocks and there's a Subway, a sandwich there, a 6-inch sandwich, the cheapest you can find for tuna 6-inch sandwich is at $6.75. Even with your food stamp allowance, you don't even have enough to even buy. And first of all, you can't use your SNAP benefits to buy here, but to buy hot foods. But if you couldn't even buy a 6-inch sandwich at Subway for your whole meal for the whole day. And if you look at the distribution of who is on SNAP benefits, it's half of them are about children. Almost 49% of SNAP recipients are children. About 20% are the elderly and disabled. And again, it's the Black and there's about 20% are Latino, and then about 26% are Black. So it is about half. But it is an issue that as cutbacks, and we're seeing increasingly legislation that's being put forward about SNAP choice, which is not really a choice. It's really kind of policing of shopping carts, of the allegations that people who are using SNAP benefits are just buying junk food. Really, it's making it more impairments to try to access to have any. It's more cutbacks and putting more kind of barriers for folks to try to tap into to get access to food. So next slide. So there's a lot going on in this slide here, but so we have this right now in recent years, anti-obesity medications. We've heard them Mounjaro, Ozempic, there's Wegovy, there's a lot of them that are really at the cusp of really changing up the game here, that really kind of change how we can control obesity. And so it's a pharmacological intervention that is I mean, there's a patchwork of like kind of school nutrition, dietary exercise. A lot of that stuff is important as well, but this is a real game changer in terms of how we can really control the obesity epidemic, and with that, preventing the $1 million patient. Right now, so the medical expenditures panel survey, which is a bit old, this data is a little bit old. If you look at the upper left, you'll see that the majority of the out-of-pocket, the obesity medications are being paid for out of pocket. About 70% are paid out of pocket. But when you look at the prevalence of obesity, it doesn't see, like, obesity is not particularly manifested in folks who are Medicare or private insurance. It really is about the same, about 40% for Medicare, for private insurance, for Medicaid, for uninsured. It's between 35 and 40% for each one of those. And so you're seeing populations who are obese across different types of coverage, but yet most of the folks who are getting access to obesity medication, anti-obesity medications, are paying out of pocket. So one thing that a lot of states have been doing as of last year, or I mean, as of recent years, but like as of last year, what we have from Kaiser is about 16 states have now included anti-obesity medications in their Medicaid treatment plans, so it's in their Medicaid formularies. And so more recently, this past few months in the legislative session in Colorado and Maryland, there's bills being debated now to whether to include it in Colorado, to add Maryland and Colorado to that list. And the demand, when on survey after survey after survey, folks are saying, you know, willpower is important, but it's not enough. And there needs to be something, particularly Latinos are saying this at 66%. And then for folks who, like, when they ask them the question, should folks who are obese or diagnosed with obese or overweight have access to these medications, it's overwhelming. It's 80% say yes. So we have the opportunity to there's a demand for folks who want these medications to be covered. There's a kind of game changer. There's a real pressing need for it. And if you go to the next slide, so this is kind of at the federal level. Next slide. So the federal level, there's this intervention, there's a law has been proposed, been brought up year after year after year as a Treatment and Reduction of Obesity Act. And this act would essentially provide anti-obesity medication coverage in Medicare Part D. So for senior citizens to tap into it. Right now, Part B kind of includes intensive behavioral therapy. Basically nutritional counseling, behavioral therapy specialists, but anti-obesity medications are not covered in Medicare Part D. And what's interesting about it is that, like, somebody who used to work at CMS, it was covered under federal employee coverage. It was covered under TRICARE. It's even covered in many of the exchanges. And for military benefits, it's covered under the VA. It's just not covered in Medicare Part D. So essentially, if somebody is on, say they're in private insurance and they are employer-based insurance, or say they're in VA, or not VA, but like say they're a federal employee and they're taking, you know, Ozempic, by the time they turn 65 and they go on to Medicare, they will no longer be eligible for that. So what's most interesting about this is that because of so Medicare has a transformational power to, whatever's included in the regimens for Medicare often becomes adopted by private employer-based insurance plans. So including anti-obesity medications in Medicare Part D could have the potential to have spillover effects into basically making it widespread. So having access to anti-obesity medications is a game changer. It is a possibility. This law would essentially help enable it. Right now it's being held up in Congress. There's debate about the cost. But again, I keep on stressing the idea of the cost of inaction. It's not so much it's how much it costs now, it's how much it'll cost later. And so to prevent the $1 million patient, and it's not just sometimes about cost, it's the idea of having life expectancy be extended longer. To kind of wrap up on my situation, my mom, like, you know, my mom by her late 50s was around 535 pounds. My sister is a medical doctor, myself, we did a lot of intervention with her to try to get her to reduce down. She was at really high risk for bariatric surgery. But she ended up just with a lot of control of diet, nutrition, kind of forcing her. She was really kind of we weren't on our favorite list, but what it did do, she managed to lose about 235 pounds. Now, my mom's case is extremely exceptional, extremely exceptional. Unfortunately, she passed away much younger than when like my mother's mother, my grandmother lived up to 109. My mother only lived up to 73 years old. But a good thing, I closed with this last slide. She was able to see me graduate. So in the final years, at least, we managed to have her live a little bit longer and a little bit more healthy life. But I can just only imagine if she had access to anti-obesity medications at an earlier age, how much different it would be. She wouldn't be the $1 million patient. She wouldn't have the diabetes. She could reverse the diabetes. She wouldn't have the problems with sleep apnea, many of these other conditions that folks are struggling with. So with that, I'll turn it over.
Thank you, Dr. Serrano. At the end of the panel session, we'll have a Q&A session. So please feel free to write your questions in the chat box. Let's continue with our second poll question. In your opinion, what improvements could be made in the healthcare services for menopausal women? And see the options below. There you go. More comprehensive education and counseling, access to a wider range of treatment options, increased research and development of menopause-specific treatments, or other. And please specify in the chat. I'll give you 1 minute. All right, let's look at the results. See here. So again, in your opinion, what improvements could be made in healthcare services for menopausal women? And the poll results of 41% said access to a wider range of treatment options. 27% said increased research of menopause-specific treatments. 23% said more comprehensive education and counseling, and 9% said other. And I don't know if we have anything specific in the chat, but all right, thank you for that. And all right. Oops. As we continue our discussion about women's health, we'll be focusing on menopause. Menopause is a natural biological process that occurs in women, marking the end of one's menstrual cycles, diagnosed after one has gone 12 months without a menstrual period. Menopause can happen in your 40s and 50s, but the average age is 51. Let's hear more about this topic with Ms. Claire Gill, who joined the Bone Health and Osteoporosis Foundation, formerly the National Osteoporosis Foundation, in January 2013. After a 20-plus year career in public relations for national nonprofit organizations and public relations firms, serving Fortune 500 clients. She was named CEO in May 2020 and then led the organization through an 18-month rebrand process. Established in 1984, BHOF is the nation's leading health organization dedicated to preventing osteoporosis and broken bones, promoting strong bones for life, and reducing human suffering through programs of public and clinical and clinician awareness, education, advocacy, and research. In September 2019, Claire founded and launched the National Menopause Foundation. Today, Ms. Gill will speak about key challenges menopausal women face. Welcome, Ms. Gill.
It's my pleasure to be here. I think what was missing from the poll answers to our last question were all of the above, which would be very, very and are all needed when it comes to assisting women in the menopause. Next slide, please. We can skip that too. So as mentioned, I founded the National Menopause Foundation in 2018. Realizing there was a real need to address educational and community aspects of menopause that we're experiencing. So I I was maybe the first one to be part of a national nonprofit solely directed to women at menopause, but fortunately we're not the only ones now, and there are great elements of support available to people. So let's talk a little bit more about menopause and what is menopause. Next slide, please. Menopause, as was mentioned, is just a natural stage of life, yet it's something that no one tells women about to help them anticipate to come. The stage of women's reproductive screening menopause, which is again from birth through puberty, etc. Then our reproductive years, etc. Then perimenopause. Think about when we think about menopause. It's some symptoms we start to experience. Hot flashes. Those are typically called vasomotor. There's sleep disturbances, there's hair loss, there's change in our skin condition, there's painful sex, all of these things happening to us. And because of the transition, women don't realize that this actually starts about 5 to 7 years, sometimes up to 10 years before your menstrual cycle stops, which is what menopause is. It's when your body and your periods, your menstrual cycle has stopped for 12 consecutive months. That's menopause. Everything before is perimenopause and everything after is postmenopause. So if you're looking at these ages, again, for perimenopause, for most women, it begins in our early to mid 40s. And so if people start experiencing those symptoms where you might still be also having children, which is certainly my case, a child in my early 40s, and then immediately after that was starting to experience perimenopausal symptoms, and that just seems very confusing to women. So again, it's really important that we know about these stages. The average age of menopause, as was mentioned earlier, is about 51. And for Latina women, that is the same. It pretty much is across all races and ethnicities. The average is 51. Black women sometimes experience menopausal, the onset of menopause a couple of months, like 8 months earlier, but the majority is around 51. That does not mean, however, if your menstrual cycle ceases completely in your 40s, that that's abnormal. That is normal for you. It's very individual for all women. So just keep in mind when we're talking here about different types of symptoms and such, we're talking averages, and anything outside of that is still normal. So be prepared and know the questions to ask your clinician, and we'll talk through that a little bit to be able to be better prepared about it. And to help provide solutions to women, we need to know what this process is. Next slide, please. So what are the most common symptoms of menopause and the menopausal transition? As I mentioned, vasomotor symptoms, those hot flashes, night sweats, those are the things that are most common. And actually, Latina women do experience the vasomotor symptoms to a greater degree than white women. Both Black women and Latino experience symptoms, most common and most frequent symptom. There's also changes that happen in our sexual health, dryness and painful sex symptoms. Those are also high in Latino women. And these are not topics that we normally talk about. But when it comes to our health, this is an element that's incredibly important and that we should be able to get solutions for and have access to both providers who can talk with us about these issues that we're experiencing, and also treatments to be able to address these symptoms. Difficulty sleeping, insomnia, those are other areas that, again, incredibly common for all women who are going through the menopausal transition. But if you don't know that you've entered perimenopause, then you might be wondering why your sleep habits have been changing so dramatically. And so again, it's really important that all women know that these are some of the most common symptoms. There are 34 roughly symptoms of menopause, however. So again, oftentimes women might be experiencing symptoms as they've moved into their mid-40s and onward and not realizing that that's part of the menopausal journey. And if you go see a clinical provider who also doesn't understand the menopausal journey, then there's a lot of confusion there. And that's part of what we need to address through our legislative action, is ensuring that providers know about women's health, and particularly about women's midlife health, so that they can address these concerns when their patients come in to speak about them. Next slide, please. So how do you know, again, if perimenopause has started, if that might be what's happening to you or someone in your family? Perimenopause is basically defined by having 3 of any of these symptoms. So again, menstrual cycle starts to change for women. They might have, again, problems sleeping, problems staying asleep, migraines, mood swings. These are things that often become more common as we go through the menopausal transitions. Obviously, you might have migraines continuing, or suffer from throughout different periods of your life, but they might intensify. So that's something to be, cognizant of. And as was just discussed earlier about, the obesity issue we have in the United States, well, weight gain and changes within our body also happen at menopause. So obesity can be become a problem at the onset of menopause, where it might not have been earlier in life. So all the things that were just discussed earlier are really important when we think about women journeying through the menopausal transition. Next, please. As I mentioned, menopause itself is the season of a menstrual cycle for 12 consecutive months. And that's really important for people to know as well, because if a woman might experience, spot bleeding or have something happen in between her monthly cycle, but not her full monthly cycle, that is still not considered a 12-month succession. So again, it needs to be defined, and women need to talk with their provider about it so they can understand it. And we need to have providers who understand that as well. Next slide, please.
That's true. So I
the other major issue. The other major issues that we worry about as we enter menopause are that because of the lack of estrogen, we have an increased risk for other diseases and conditions. Osteoporosis, clearly from my role as the CEO of the Bone Health and Osteoporosis, this is incredibly important, and we need to make sure that more women and men know that osteoporosis is very common in the United States. 54 million Americans have osteoporosis or low bone mass, which means that they're at a greater risk for fracturing. A woman's risk of breast cancer also increases during the menopausal transition, and her risk of heart disease also raises during the menopausal transition and post-menopause. So as we're talking through all of the other issues related to Latina and Hispanic health, we really need to think about all of these conditions as well, and making sure that people have access to the screenings, to the treatments, and to providers who are available to address all of these needs in women's health. Again, it's complicated as we go through the menopausal transition because we become susceptible or at higher risk to these other conditions. And the providers need to know that that is something to look out for as women begins perimenopausal symptoms, and making sure that they have a baseline on what is their bone density at the start of their menopausal journey versus where they might be postmenopausal. For osteoporosis, women can lose up to 20% of their bone density in the first 5 to 7 years postmenopause. So again, really important that we pay attention to these things, that we are educated about these different conditions that impact us as we move through the menopausal journey, and that we have access to both the providers who are able to address these concerns with us and to affordable treatments. One second I'd like to spend on one of the treatments for menopausal symptoms is hormone replacement therapy. And about 20 years ago, the Women's Health Initiative came out and indicated that hormone replacement therapy were actually indicated as raising a woman's risk for breast cancer and heart disease. Well, what we now know 20 years later is that wasn't correct. What the study was looking at were not women who had taken hormone replacement therapy at the onset of menopause, but rather looking at women who were older and postmenopausal and on hormone replacement therapy. And that made a very big difference. So I do want both clinicians, providers, those who are overseeing policy related to women's health to understand that hormone replacement therapy is both safe and effective for women going through the menopausal transition, and therefore women need to have that treatment available and accessible and affordable to them as they go through the menopausal journey. Next slide, please. The National Menopause Foundation partnered with Bank of America last year to go through a study about menopause in the workplace. And this applies very much to when we talk about what are some of the legislative changes that we need to be thinking about to address women's health, and particularly women's menopausal health. And what we found was that women were really uncertain about what culture was within their workplace to be able to address some of these symptoms that they're experiencing. Women tend to be at the prime of their careers as they're going through the menopausal transition. And so we want to make sure that we accommodate and make sure we can keep them in the workforce. And when we talked with the HR departments of these offices, they all felt that it was a very welcoming, culture that would absolutely address women's needs in menopause. And yet many women, as you see from this, felt that most of them said they don't know what the reaction would be to be discussing their menopausal needs within the office space. 27% said that it was negative, and 32% said they felt that they were supported and that there was a comfortable discussion about, midlife health in their policies at work. So we definitely have a lot to do to make sure that this becomes 100% of people feeling that it's a positive culture to talk about, again, a normal stage of women's life, but one that can have dramatic impact on our quality of life and our work life as well. So it's really something to be paying attention to. I think that's it, but next slide, please. Yep, this is just information about how you can contact me for more information. Thank you so much. Thank you for allowing me to come speak on this very important topic.
Thank you, Ms. Gill. And again, I would like to remind everyone that at the end of the panel session, we will have a Q&A session. Please feel free to write your questions in the chat box. And before continuing with our next topic, we'll move on to our third poll question. That poll question is, are you aware of any recent congressional proposals aimed at improving Medicare drug coverage? And the options are below. There we go. Yes, no, or unsure. We'll provide you a minute, maybe a little bit less, to choose. Please note you can write other options in the chat box, and we'll give you up to 1 minute. All right, maybe let's look at the results. Here we go. And again, the question is, are you aware of any recent congressional proposals aimed at improving Medicare drug coverage? And 52% said no, 30% said yes, and 17% said unsure. So that's interesting. So only 30% said yes. All right, we'll move on from that.
Completely fills up. And so to have somebody who would be in a...
I'm sorry about that. Medicare Part D helps cover the cost of prescription drugs. Medicare Part D is optional and only provided through private insurance companies approved by the federal government. However, Part D is offered to everyone who qualifies for Medicare. But let's hear more from our next panelist. Joel White is the president of the Council for Affordable Health Coverage, a role he has held since 2008. Founded in 2001, CAHC is a nonprofit advocacy alliance of the nation's largest employers, drug manufacturers, health insurers, and patient organizations with a singular focus, bringing down the cost of healthcare so that every American has access to affordable health coverage. The Council for Affordable Health Coverage has helped advocate for more than a dozen laws since Joel took the helm. Today, Mr. White will highlight congressional activities this year as it relates to Medicare Part D. Welcome, Mr. White.
Thank you. Really appreciate the opportunity to be here today and to chat a little bit about Medicare Part D. You can go to my, my slides. So just to give you a little bit of background, I was on the original team at Ways and Means that helped create the Part D program. And that was in 2003. So 21 years later, Part D looks very different, and it's changing a lot for seniors, the disabled. And I wanted to talk a little bit about that, but to provide some context first, I wanted to talk about where Congress is at, what they're focused on. If you want to go to the next slide. So we're right in the middle of a hot time for Congress, and there's the funding issues that keep the lights on and keep the government operating is primary focus for the month of March. There's two primary packages that are being considered. The first one has already passed the House, passed yesterday by a vote of 339 to 85. So overwhelming bipartisan support, basically made up of 6 separate appropriation bills, or about half the government. It's gone over to the Senate. The Senate will probably take that up on Friday, be sent to the president and signed. But we're not out of the gate yet. Part of that package included a number of healthcare policy extenders and things that would help extend policies and provide funding for things like community health centers and other providers to make sure people continue to have access to care. Otherwise, that funding would go away and people would lose access. The next kind of shoe to drop is the second package, which is the other 6 appropriation bills, including Health and Human Services, to keep all those programs at Department of Health and Human Services funded and running. Right now, those programs are funded through March 22nd under a continuing resolution. We are expecting this package to come out on Sunday, and that it should be resolved. Again, the House will probably pass it with strong bipartisan support. It'll go to the Senate and then go to the president. So we're not expecting the government to shut down or anything like that. But what's happening as a dynamic here is that a lot of the extenders that I talked about in package 1 are kind of getting pushed to the end of the year. And that's being added to a number of Medicare provisions, like expiring telehealth access that is ending on December 31st. And so we're seeing a big set of issues that expire at the end of the year that will need to be addressed in the lame duck after the election, but before the new Congress is sworn in. And at the same time, we know that Medicare physicians get reimbursed in the program. They will probably be cut again. They've been cut almost every year for a long time. We're expecting that again this year, and Congress has a deep interest in ensuring Medicare increases spending for doctors so that people continue to have access to their physicians. Now, in terms of the timeline, this is an election year. I'm not sharing any state secrets there. But throughout the year, certain things are going to happen. And the first kind of thing in the Part D space is in late July, early August. We'll know Part D premiums and what those look like. But we won't know what the specific plans that Medicare beneficiaries sign up for, what their premiums will be, what their coverage options will be, until the annual open enrollment period begins on October 15th. That's just a couple of weeks before the election, and that's going to have significant political implications because premiums in Part D are going up, and they're going up significantly. So wanted to get into that. But first, if you go to the next slide, I wanted to show you what was in that March 1st package. Quite a bit of funding for a lot of different healthcare items. So physicians, hospitals, community health centers, special diabetes program, a lot of stuff in there on mental health and substance use. I'm happy to share these slides afterwards. I'm not going to go through all the detail here. The point is that you see those funding streams, most of them end at the end of 2024. Again, teeing up a big package in the lame duck focused on healthcare, that becomes an opportunity for Congress to address some things they haven't taken care of yet in new policies. That includes, many of you may have heard of PBM reform, and there's a lot of things in there on Part D that would change how benefits are managed by these pharmacy benefit managers, including requiring price discounts to be passed through to the consumer. And so that's a key issue and point of contention in Congress right now. Whether that makes it to the finish line yet or not, we're not sure, but it's certainly in the mix, and certainly something that would change how much consumers pay for their medicines at the pharmacy counter. And you can go to the next slide. So the reason there's a lot of change in Part D right now is because of the Inflation Reduction Act. And you can see the timeline here. The Inflation Reduction Act has already been implemented in certain areas. More things are being rolled out. And so already we've seen inflation rebates. That's where manufacturers have to pay a rebate if their drug prices increase faster than normal inflation. Also, elimination of cost sharing on vaccines and a cap on insulin in Part D plans at no more than $35 a month. Tonight, the president's going to suggest extending those inflation rebates and the $35 insulin cap to all employer coverage and private coverage. And so that would be a significant change. This year, we'll get into this in more detail in a second, we eliminated the cost sharing for beneficiaries above their annual out-of-pocket limit, which was a significant change. But in 2025 is really when the significant stuff starts hitting. It lowers the amount that Medicare beneficiaries have to pay out of pocket to $2,000. And then in 2026, drug price controls, or the drug negotiation program, will start. It initially starts with 10 drugs and then adds to that every year, 15, and then ultimately 20 new drugs every year, to where most drugs in the Medicare program would be price controlled. And that's going to change the availability of products and what type of products are available to consumers. If you go to the next slide. So what does Part D redesign look like? And I don't want you to focus on a lot of the details. What I want you to notice is that in 2023, there's a lot of orange. That orange represents how much consumers pay out of pocket. And you can see pay 100% of their deductible to start out, and then the Part D plan pays 75% of the costs up to a certain limit. And then there's what's called the coverage gap, where manufacturers really fill in 70%, plans pay for 5%. And then at a total limit, an out-of-pocket limit, beneficiaries in 2023 were still paying 5%. The big difference between 2023 and 2024 is that 5% got eliminated. That means that once I hit my annual out-of-pocket limit, I'm no longer responsible for any more costs. But then the second thing I want you to notice is between 2023 and 2025, it goes from a lot of orange to a lot of blue. That blue is the liability that insurers, or the risk insurers, are taking on in covering the costs for prescription drugs. And so in 2025, the law reduces the annual limit from about $3,250 to about $2,000 hard out-of-pocket cap. So no Medicare beneficiary will pay more than $2,000 after 2025. That is a significant change, but it also places a lot more risk on the insurers. And so homeowners insurance on a $10 million house costs a lot more in a premium than homeowners insurance on a $100,000 house. So if you have a richer benefit, you're going to have a lot higher premium. And that's what we're seeing in the market today. In 2024, premiums are increasing on average by about 22%. And in 2025, when more of that blue comes into play, we're expecting at least 50, maybe even a doubling of the premiums in Medicare Part D. So let's go to the next slide and take a look at that. So just on the premium side, you can see on the first chart there, the yellow line represents the average premium. And you can see it's pretty stable since 2020. If you went back even further, premiums were typically somewhere between $30 and $35. Really, Part D is a competitive market, and as plans compete, they were able to hold premiums pretty steady over a very long period of time, kind of unheard of in the insurance world, where we see most premiums just go up and up and up. But between 2023 and 2024, when we eliminated that 5%, what we saw was that 22% premium increase. So we went from about $40 to about $48. That's a significant change, and you can see that in the blue on the right. But at the same time, what we're seeing in Medicare Advantage, or the comprehensive Medicare program plans, is premiums are actually going down a little bit. And so as seniors and the disabled, maybe on fixed incomes, are looking at their options, they're seeing a big increase in Part D and a reduction in Medicare Advantage. More people are choosing the Medicare Advantage option over Part D, and we expect that trend to continue into 2025 as more and more people are faced constrained wallets. So in Medicare Advantage, 51% of beneficiaries are currently enrolled. And like I said, we expect the trend to accelerate based on this premium differential. The other point I wanted to make on this slide is that the Inflation Reduction Act sought to hold premiums to just 6% cost growth. So we're seeing 22%. How's that possible? Well, the law was written in a way to only affect part of the beneficiary's premium, not the whole thing or what people experience in the marketplace. And I think some members of Congress are starting to rethink how do we change that 6% cap on premium increases to better protect seniors and the disabled. You want to go to the next slide? So not just premiums, this more insurance risk and these changes as a result of the Inflation Reduction Act is also impacting beneficiary access to different plans or choice of plans. So as was mentioned at the beginning, Part D is a voluntary benefit. People choose to sign up for it, and they have a choice of about 43 different plans in 2024 on average. That means they've got to look and see what works best for them. Some of them have zero deductibles. Some of them have $0 premiums. Some of them do a really good job covering generics. Others focus on specific diseases like diabetes or obesity related conditions. So the choice, though, that most seniors and the disabled are facing has really declined. So in 2006, the first year of the benefit, there was about 1,400 plans. This year, about half that, so about a 50% reduction, and those plans are getting more and more similar. The second point on this slide is that for low-income seniors, Medicare beneficiaries, they get their premiums mostly subsidized and their out-of-pocket costs mostly free. And so, but they have to sign up for a low-income subsidy plan. And right now, in 2024, we have the least number of low-income plans ever. So it makes it a lot harder for a low-income individual to find a plan that both meets their needs and provides that extra help to be able to afford premiums and out-of-pocket costs. You go to the next slide. And then last kind of data point, and I'll talk about the implications. Part D is getting more expensive and there's fewer choices. Medicare Advantage, the premiums are going down, but one issue on the policy side that's starting to get looked at by members of Congress is, are we paying too much for Medicare Advantage? And MedPAC, which is the advisory committee to Congress on Medicare, compares spending in Medicare Advantage, comprehensive health benefits, to what a senior might pay in fee-for-service if they were enrolled in fee-for-service, and how much that person would cost. And they account for differences, they control for things, but basically what they found was that on average, Medicare Advantage was being paid 123% of the typical fee-for-service rate, or 23% more than the costs of a fee-for-service beneficiary. that translates into about $88 billion more in total in Medicare Advantage compared to fee-for-service. And so some Democrats and Republicans are starting to look at Medicare Advantage and say, maybe we're paying too much for Medicare Advantage. Maybe we ought to look at ways to reduce that cost in the context of deficit reduction and using that money to maybe fund other things. So if you go to the next slide, I want to talk about the implications of all this. And the point is that we've got more insurance risk in Part D. That's leading to higher premiums. If you're an insurance company, one of the ways that you manage more risk is you manage the utilization of drugs. And that means more prior authorizations, maybe more step therapy, maybe more restrictive formularies or the list of drugs that are covered. We're also seeing fewer choices as more plans exit the market, and we expect many more Part D plans to leave the market in 2025 because the insurance risk goes up. And then that accelerated migration into Medicare Advantage plans where taxpayers are paying more. So I think some of the potential responses Congress is considering is, one, why don't we reduce payments to Medicare Advantage and put that money into Part D to hold premiums down? The second thing is maybe we tell the insurers in Medicare to do a better job authorizing access for patients. And you see the Gold Card Act there. That's a Burgess effort to say if you're a doc, you can, and you're a good doc, we can expedite your approval for beneficiary access. On the other side, the Inflation Reduction Act imposes those price controls, and there's more. We expect fewer products in total. We expect more biologics and fewer pills, where people get access in a doctor's office or a hospital rather than a pharmacy for different reasons. And then there's also disincentives to create rare disease.
Yeah, that makes a lot of sense. Okay, cool. I have a
So a couple bills there. They're all bipartisan. The first is the EPIC Act that would address the incentive to create more biologics versus pills. There's another bill, the Orphan Cures Act, again bipartisan, Joyce and Nickel, to address the disincentives to produce products for rare diseases, and then addressing the anti-innovation incentives here, maybe Cures 2.0, doing some FDA reforms, getting more clinical trials, bringing AI to bear on drug discovery, and maybe replacing the drug price controls with mandatory discounts for older products, getting rid of the bureaucracy and just passing those savings off to consumers. So there's a lot in play because the IRA, the Inflation Reduction Act, changed a lot, and seniors were promised lower drug costs. I think all they're seeing this year is higher premiums. So a lot of work to do here on Part D. And sorry, the last thing I wanted to mention was obesity coverage, because that was the first topic. Medicare currently doesn't cover obesity products. There is legislation to address that. It's bipartisan, HR 4818, and that would add obesity to the list of drugs that Medicare actually covers. Got a lot of bipartisan support and a lot of interest with the new therapies that are on the market now. So that's also in the mix. So appreciate the time today. Really appreciate the organization for everything you're doing to educate and advocate.
And thank you, Mr. White. And before we move on to our final poll question, maybe we can look at the results of the first poll question, which I skipped over. And I don't know if we can do that now. There we go. Just as a reminder, the first poll question was, what do you believe are the main factors contributing to the high rates of obesity among Latinos? And we look at the results. 41% said socioeconomic factors. 29% said lack of access to healthy food options. Here we go. 18% said cultural dietary habits. 12% said other. And 0% just said limited opportunities or physical activity. Okay, thank you for that. And now we will move on to our final poll question here. And that question is, Which one of these options do you think can improve the accessibility and effectiveness of COVID-19 treatments and resources? And the options below, which you can see, are increased funding for research and development, improved distribution channels, better communication of information, or other. Please specify that in the chat, and we will provide a minute for you to choose. Please note you can write other options in the chat box. All right, we'll give you 1 minute. Okay, here we go. Let us look at the poll results. Again, the question was, which one of these options do you think can improve the accessibility and effectiveness of COVID-19 treatments and resources? And 50% said improve distribution channels, makes sense. 44% said better communication of information. 6% said other, all of the above. And 0% said increase funding for research and development. Okay, that's interesting. All right, thank you very much. Oops. Okay, let's move this. All right, thank you all again for participating in these polls. And before continuing, there's time for you to send us your questions for the Q&A session that we'll do at the end. Feel free to type the questions in the chat box. As we all know, COVID-19 has disproportionately affected certain underserved and high-risk populations, including people of color and those who are socioeconomically disadvantaged. Because many of these groups remain at increased risk of exposure, given that they are less likely to work in jobs that can be done remotely, and due to other structural factors, access to treatments in addition to vaccines is particularly important. We want to highlight that COVID-19 is not over, and there is treatment available for everyone who gets infected with this virus. But let's hear more about this topic with our next speaker, Dr. Hector Cabrera. Dr. Cabrera serves as Associate Chief Medical Officer for Premier Health. Now approaching 100 clinics in 13 states, Premier Health is one of the leading urgent care operators in the US. Dr. Cabrera has served as Medical Director of LCMC Health Urgent Care in New Orleans since 2019. Dr. Cabrera serves as Associate Chief Medical Officer for Premier Health. Now, we already said that. All right, today Dr. Cabrera will highlight COVID-19 treatment and resources. Welcome, Dr. Cabrera.
Hello, everyone. Thank you so much for inviting me to be here. I'm happy to share what I've learned in my practice. My name is Dr. Hector Cabrera. I'm a family practice doctor. I work in Louisiana, in the New Orleans area, primarily in urgent care. I'm the Associate Chief Medical Officer of Premier Health and the Medical Director of our LCMC clinics here in New Orleans. And I hate to break the news to you, but COVID is still out there. We're seeing a lot of patients with COVID illness in the urgent cares. The good news, though, is that it seems to be milder cases. Fewer of the patients I encounter in the urgent care have severe disease, and I have to transport to the hospital. Most of them have milder illness. That's the good news. I still worry a lot about our Latino community because I still have very few patients that come in seeking COVID antiviral treatments. And that worries me that maybe there isn't as much awareness in our community about these very effective, very safe treatments in our community. And some of the CDC data does back this up. There's evidence from 2023, from last year, that the CDC has published that shows underutilization of COVID antivirals in the Latino community. And we're still being disproportionately effective. Latinos have a 1.5 times greater rate of becoming infected, 1.8 times greater rate of needing hospitalization, and 1.7 times a greater rate of dying from COVID illness. And this was data from last year. So we still have some work to do. And I'm glad you're here to join us. I'm going to talk a little bit about COVID antivirals, what they are. I'm going to talk about the risk factors. What puts a person at risk of developing severe disease? Who do these COVID antivirals are meant for, or best to be treated with? And then I'm going to talk a little bit about how to access them, okay, in this time. So COVID antivirals, there's 3 of them that are available. One of them, remdesivir, is very effective, but it requires an IV transfusion. So it's the one that you're going to get in the hospital if you're hospitalized. In the clinics, your primary doctor or pediatrician or the urgent care will mainly prescribe the 2 oral COVID antivirals. One of them is called Paxlovid. It's very effective, 88% risk reduction. That means if you take the medicine, reduces your risk of developing severe disease, hospitalization, and death by 88%. Very effective. It's approved for 12 years and above. It's safe to use in pregnancy and utilized by a lot of OBGYNs because pregnancy is a risk factor for severe disease. But Paxlovid has a lot of drug-drug interactions. And so it's very important to be honest with your prescribing physician, let them know everything you're taking, including natural herbs and supplements, because Paxlovid can interact with some of those. Most of them can be managed. Either you hold them for the time you're taking the Paxlovid, or you reduce the dose. But in a few cases, you can't take Paxlovid. Our alternative is a medicine called Lagevrio or molnupiravir. Again, it's also an antiviral, helps your body fight the viral infection, helps you feel better quicker, and does reduce your risk of developing that severe disease. Not quite as efficacious as Paxlovid. It's about a 30 to 35% risk reduction, but there's no drug-drug interaction, no need to adjust for renal disease, and approved for 18 and above. This one cannot be used in pregnancy, but it's a good alternative for those of our patients that can't take Paxlovid. They're safe, they're effective, they'll help reduce your risk of developing severe disease and ending up in the hospital. Now, who's to benefit the most from these COVID antivirals? It's patients that are at high risk for developing severe disease. And there's really 4 factors that your physician is going to analyze to see if this medicine is needed for you. We look at the age, number 1. The older you are, the higher your risk of developing that severe disease, particularly 65 and above. But there's good evidence that 50 and above will benefit from the COVID antivirals. The younger you are, the less risk you have. So if you're less than 50 or less than 30, the lower your risk is. So age is a factor. Second factor is medical illnesses that can sometimes put you at higher risk. There's a bunch of them that we've discovered that can make you higher risk of developing that severe disease. And the more of those illnesses you have, the higher your risk. I'm talking of illnesses like diabetes, hypertension, obesity, smoking, all diseases that are very prevalent in our community. Asthma, lung disease like emphysema, heart disease, kidney disease, all those illnesses put you at a little bit higher risk of developing severe COVID. The more you have them, 3 or more is the highest risk. If you have 1 or none of them, then it's lower risk. So age, medical conditions. Next is vaccination status. Obviously, the highest risk are those people who never received any COVID vaccine. The best protection, the lowest risk, are people who received all their initial vaccinations plus the most recent booster. And I will mention, there is a recent booster that's effective against the variants that's out there. Recommend people that are at high risk of getting it. The CDC recently put out a recommendation that people 65 or older, or those that are at high risk, get another booster right now in the spring. You can get it if you've had your previous booster greater than 4 months before. Okay. The last factor, so age, number of medical illnesses, vaccination status, and then the last factor that we look at is immunosuppression. So there are certain illnesses or treatments for illnesses that weaken a person's immune system. The ones that put the patient at the highest risk, think of those blood cancers like lymphoma, leukemia, or someone who's undergone a stem cell transplant. Those are at highest risk. Probably next are those patients that are on really strong medicines to suppress the immune system because they've received an organ transplant. And then less risk on the scale are probably medical conditions that require medicines that suppress your immune system a little bit, like antimetabolites, like methotrexate for people who have rheumatoid arthritis or other illnesses. Some of the injectables, like medicines that suppress, that are also used for psoriasis or rheumatoid arthritis. There's some illnesses that require patients to take prednisone or steroids every day. All those medicines weaken your immune system and increase your risk. And so immunosuppression is the next thing. Those are the factors that you consider. It's good for you to analyze your own risk factors. And so that way, if you develop symptoms, we recommend that you get tested. And if you're at risk, seek treatment. Okay? Seek treatment. Go to your doctor's office, get your illness confirmed, and then see if you're a candidate for one of these medications. There's been a change that happened with the official declaration of the end of the pandemic. Initially, there was a government-purchased supply of these medications that were free for all, and so since the end of the official declaration of the emergency, these medicines have become commercialized. That means that they have to be purchased at the pharmacy. That free supply has dwindled and been exhausted, and so now you need your insurance or you need to pay for the medication. What I would inform, most federal programs, your Medicare, Medicaids, TRICARE, if you're in the military, the medication is free for you and covered by those plans. There is help out there to help with copays in your insurance or to help if you're uninsured. And I would seek that help through Pfizer for Paxlovid and through Lagevrio through their websites directly. There's copay cards and patient assistance programs that you can apply for. Ask your doctor. A lot of times they have knowledge of these resources and may have those patient assistant cards or flyers right in their office. So when they prescribe that, you can get it, but you can also go to the website to seek that information. In summary, I would tell you that COVID isn't gone. It's still there, but it's changed. We see less severe cases, thankfully, because the vaccinations are still effective against this variant. There's more people that have had this disease and have some natural immunity, and because there's very effective treatments, the COVID antivirals. I think it's important to know that they're out there, to know your risk factors, like we discussed, those 4 factors: age, medical conditions, vaccination status, and immunosuppressive illnesses that you may have. Know where you stand, know where your family members stand. So if you develop upper respiratory symptoms, then get tested and seek treatment. Okay, I want to see more of our Latino community members coming to seek that treatment in the clinic than what I'm seeing now.
All right, thank you, Dr. Cabrera. Also, we want to share the following 2 slides, I think you see there now, about COVID-19 treatment resources for your review. And again, thank you to all the panelists and wonderful presentations. As we end this panel session, we'll now turn over to our Q&A session. And the first question we received is for Dr. Serrano. And that question is, with regards to the obesity topic, is there research around the BMI metric not being the adequate marker of obesity of diverse communities? I've oftentimes felt that Black and Brown communities are held to a standard that is not necessarily indicative of the life and lifestyles of our communities of color. So that's for Dr. Serrano. I can repeat that if you want, Doctor.
There we go. Can you hear me?
Yes.
Yeah, I mean, the issue of BMI I used to work with the World Health Organization. It's an issue that comes up quite often when you see metrics, kind of a one-size-fits-all metrics that are used, particularly for the Asian community, because like a lot of times like their BMIs tend to be lower. And so the idea of like assessing obesity on that level, for Asian Americans, you don't really quite capture the real story there. I think for Black and Brown communities, we do see that. I suspect that it could be, if it was modified. I mean, I think the numbers are still disproportionately higher compared to the white population. But I think if you had if it was obviously there's body shapes are in different. I mean, for Black and Brown, it's different. But I think it would. I don't know if it would still address the issue of the disparity. I think you would see it be lower. It might be lower than 49% for African Americans and 46% for Latinos, but the disparity between excess weight and obesity for Latinos compared to white, it would still be higher, I think, and so that's the challenge. But the other thing I can just speak on that is the kind of cultural. I mean, it's quite often we see it Latinos like in public health, we see them as kind of a language minority, but it's not really a language minority. There you have language issues, you have cultural issues, you have class issues. There's a lot of things that are impairing or impeding people's utilization of healthcare services, nutritional information, health literacy. A lot of those factors come into it. I think with Latinos, you really quite see it's a pretty dire situation. I think when you see understanding of nutritional facts, understanding of like the built environment, understanding what is healthy, what is not a healthy caloric intake, portion size, and even perceptions of medications like the anti-obesity medications. There's still a lot of work to be done in this community.
Perfect. Thank you, Dr. Serrano. The next question is for Claire Gill. What specific steps can healthcare providers take to support Latina women going through menopause?
The best thing that healthcare providers can do is to initiate the conversation and ask the question with their female patients who are in their early to mid 40s and beyond, to just address what symptoms they might have, to acknowledge that they might have additional symptoms. So oftentimes women feel nervous about asking it, or as I mentioned earlier, may not know that some of the symptoms they're experiencing are normal on our perimenopausal symptoms. So I suggest asking, have you been experiencing any symptoms that you'd like to talk about? And just reminding them that, perimenopause starts around this age and it's very normal. And so if there's anything you'd like to discuss with me, please do. That would be amazing. And the other thing is for clinicians to make sure that they stay up on all of the latest information about menopause and how to address the health conditions of women at menopause. The Menopause Society, which used to be the the North American Menopause Society, they rebranded to the Menopause Society, and it's menopause.org. And they have continuing medical education and a certification program for clinicians to become a menopause certified practitioner. So again, if this is a particular interest, then that's an opportunity to participate and get more knowledge on how to address the needs of women at menopause.
Thank you. The next question is again for you, Ms. Gill. Why is it a taboo to talk about menopause among women and with healthcare providers?
It shouldn't be, as it's just a standard, again, normal, part of life. However, I think it's been wrapped up in our cultural, assumptions about women and aging. We obviously have an issue with ageism in this country as well. And so I don't think women want to identify themselves as getting older. And that's what menopause has symbolized for many, many years. And that's changing, thank goodness. As we're living longer, we're realizing that we're not old when we enter menopause. We really are at midlife and have a long and active life ahead of us. So it shouldn't be, but unfortunately it is. And there are cultural issues with that as well. In Japan, I'll point out though that they celebrate the menopausal transition, and it would be wonderful if we were to be able to make that something that became standard throughout. We celebrate when our young people go through puberty and realize what an amazing transition this is for them and how it's a new stage of life for them. And yet we look negatively on it when it's another transition from reproductive years to menopausal years. So I think we have a lot of work to do on that. On the provider side, I really do believe it's sort of lack of education. Many clinicians have told us that there are 4 sides, just 4, in all of medical school that address menopause. And so when they're not really educated about it, then they don't realize how much of an impact it has on women, and therefore they don't bring it up. And they also might think, well, it's just something women have to deal with. But I keep reminding people in all the presentations I do, and particularly for women, there's no prize for suffering. We can seek solutions. And one of the colleagues I just spoke with recently mentioned to me, which I think is absolutely true, if a child of ours experienced a hot flash and then it repeated in that child, we as parents, as moms, would do anything in our power to get that child some relief from the hot flashes. And yet we don't do that for ourselves. So it's really something to think about as we think about asking for solutions to the symptoms that we're experiencing.
Right, thank you for that. The next question is for Joel White. How can Medicare policies be improved to better address the health needs of Latino older adults?
I think it's a great question. I think first and foremost, what we see is coverage gaps in Medicare Part D. I mentioned obesity, big issue at the front end of this webinar. Medicare Part D, by law, does not cover obesity products. And I can explain why that decision was made in 2003, but by law, those products are excluded. And we see these incredible new therapies that have come out that can be life-changing. And so I think, the legislation, HR 4818, the Treat and Reduce Obesity Act, again, a bipartisan bill, would love to see that signed into law. Obviously a big issue for Latinos and a lot of Americans. The second thing I think we need to do is recognize that people are struggling with their healthcare costs, particularly premiums. And in Part D, those premiums are increasing by 22%. Next year, they're going to go up maybe 50%, maybe 100%. That's not sustainable for a lot of families and a lot of individuals. And so we've got to get our arms around that. We're working with Congress right now to figure out how to appropriately address that. We don't want people to have less affordable coverage. We also want them to have robust coverage and coverage that meets their needs, including that $2,000 out-of-pocket cap. So that's something we got to figure out and is coming in the future. But the last thing I think we need to make sure is that as the Inflation Reduction Act is being implemented and these drug price negotiations and lower prices kind of come online, we need to make sure that those products are available. First of all, that they're covered by the Part D plans. They should be covered without cost sharing, in my opinion. They should be not subject to utilization management. and they should be on the formulary. They should be available across all the Part D plans. But the biggest thing that we can do for Part D is make sure that we're not producing fewer treatments and fewer cures. And so we need to, I think, revisit the logic of the Inflation Reduction Act to make sure that we continue to produce all those exciting new therapies, cures. We just had a cure for sickle cell released in December. I mean, this is an exciting time in terms of medical innovation, and I'm very concerned that we have probably the worst policy environment right now for innovation that we've ever had. So those would be 4 different ways that I think we really need to start re-examining Part D, how it operates and how it works for consumers.
Thank you. And our final question is for everyone, so feel free to jump in. What role can community organizations play in addressing health concerns in the Latino community?
I think quite often, I think for our communities, especially Latino communities, we tend to be very shy about advocating for certain things, especially when it comes to certain illnesses like obesity and menopause, or I would say illness, but health conditions like obesity, menopause, and so forth. I think it's important for us for community organizations to try to like elevate that voice and to motivate more folks to become a part of the policy space, to speak out, to write to their leaders or elected officials, to tell their stories. I tend to, like on my presentation, I tend to kind of humanize it a little bit more and talk a little bit more about my mother's condition, my family's condition. I think just because I think quite often those stories are not really told. And I think it's important for community organizations to have their ear to the ground, to really know that community, to elevate those stories and try to bring a face, to humanize a policy, humanize the numbers. So it's not just numbers and Excel spreadsheets and costs and so forth, but it's really human lives that we're dealing with, real communities, real people. I think that's one thing I think community organizations can really do.
I would agree with Dr. Serrano. I think that too often we think we don't have a voice, but our voice is actually very powerful, and we can raise that with our members of Congress. There's many tools to help you reach out and just be engaged, right? And what I see in my charitable work is a lot of times people feel disempowered, and I constantly urge them to just get online, fill out that form, send an email to your member of Congress and say, hey, look, this is what I'm living with, this is what I'm seeing, this is what I'm dealing with. I want you to work on this. It's very powerful. Having spent 12 years on Capitol Hill, I know it makes a difference in how members of Congress think and act. May not feel like it, but it's very important.
I agree with everything that's been said, and I'd also encourage people to consider, if you reach out directly to the congressional offices in Washington, but also feel free to set up a meeting or just go visit your district office of your congressional member. They too help relay what constituent questions and concerns are to the national office. And not everybody can make it to DC to meet in person with their member of Congress, but you can in the district office. So that's another tool. And as has been said, so many patient advocacy organizations have tools available to be able to reach out to members of Congress and to give you updates on issues that are related to the issues that they're supporting for. So for both the Bone Health and Osteoporosis Foundation, we have a National Bone Health Policy Institute and often share information about what's happening that impacts constituent or consumers' access to care and to screening. And you can find that on our website. And the same with the National Menopause Foundation. We launched the Women's Midlife Health Policy Institute to address all of the concerns for women at midlife. So you can get involved with the organizations and you can reach out directly to your members of Congress. And it does make a huge difference. So thank you for considering that and doing that.
Thank you. Now, I will echo that as a former longtime congressional staffer. When constituents weigh in on issues, we definitely listen. So please do that if on whatever concern you may have. Okay, thank you again to all the attendees and speakers joining today's event. Before ending, I would like to introduce Ms. Josefina Mata, Executive Director of Concilio CDS Inc., to provide closing remarks. The floor is yours, Ms. Mata.
Thank you. Thank you, Oscar. Buenos días a todos. I would first like to thank Dr. Yanira Cruz and the NHCOA team for hosting the legislative breakfast. And thank you to all of you in attendance for this tremendously critical event so that in partnership, we can continue working towards helping the communities that we serve. So that everyone has the opportunity to actively participate in creating solutions to various health inequities. Everyone can be part of the solution. It is with hope that with what is shared today by everyone, solutions are applied in support of building up our communities with the tools and skills to foster resiliency and to look beyond our communities just trying to survive, but to thrive and contribute to strengthening their communities for challenges ahead. Next slide, please. Historical health inequity challenges have affected generations of Hispanic Latino communities and have placed many in a cycle of systemic challenges that shackles individuals from being able to live healthy lifestyles and have a sense of wellness as often as the systems in place or all they are able to have access, it's still not enough to break free. Affecting the trajectory in which families fall into as many live in multi-generational households are part of the sandwich generation and face the detrimental health effects of caregiver burnout, and many are unpaid family caregivers. Now adding the lingering challenges that COVID-19 pandemic magnified, affecting families still today. This is why one solution, one initiative, or one agency to meet community needs will not be enough to address the Latino health inequities. The dimensions of a person's wellness is multiple, and as a whole person, whole community approach is desperately needed to effectively create positive change in Hispanic wellness. Next slide, please. One size does not fit all. And just as each individual has a unique health challenges, so do communities, even when they're just a few miles apart. The challenge at times with Latino populations, in particular with our older adults, are the generational experiences that they share, where they do not trust and will not accept assistance from just anywhere or anyone. And this causes struggles in accessing resources to meet basic medical care, healthy food, economic opportunity, and other resources that would assist in overall wellness. Next slide, please. According to recent data by the U.S. Census Bureau, approximately 16.8% of Hispanic Latinos lived in poverty in 2022. Placing the poverty rate well above the nation's overall poverty rate of 11.5%. Affecting the health outcomes of our Hispanic Latino families as economic instability affects transportation, the ability to access medical care, medicine, healthy food, preventive care, and other resources, on top of already existing challenges and systemic barriers. It is often highlighted that by 2030, we will have a predominant older adult population, but the reality is that we are already there. As our systems and institutional infrastructure, it's already falling behind in addressing caregiving needs. Additionally, there is a widening labor shortage due to the demographic shift, and people are aging out of the workforce, or worse yet, facing challenges of ageism. Also, within a community, an older adult with no family and due to living in a rural area may have transportation mobility issues and public transit might not be available. And if it is, they may not use it due to feeling uncomfortable because of the language barrier and a cultural disconnect. The same challenge may be experienced in a city center. However, due to infrastructure, what once was a safe neighborhood has become a highly trafficked area, causing for additional barriers to transportation and mobility, as it pertains to safety for driving older adults, thus creating a challenge for their independent living. We are uniquely positioned to address our greatest concerns through intergenerational solutions and equipping our communities with resources and with communities and opportunities to allow them to address health inequities in ways that fit their individual and unique needs. Next slide, please. Health inequity solutions applied as a whole person, whole community approach are needed, because if one element of wellness falters, the opportunity to meet community needs falls apart as it's trying to be addressed and the cycle of wellness is broken. Supporting community-based and community-led solutions, social networks in place that are already trusted at the individual community level makes it easier to address health inequities. Next slide, please. And so reskilling and upskilling Hispanic population across generations, which critically includes our growing older adult population, is key to address health inequities. Each person has an intrinsic value through their talents and experiences, and being provided a meaningful opportunity through culturally competent and culturally responsive training and education can be a step in providing Hispanic population with a necessary tool set to address health outcomes across all age groups. Next slide, please. Our government as a whole can create positive lasting change if communities are heard. And it is always with hope that our government supports those solutions, and it provides the tools and resources for solutions to be sustainable and for health inequity challenges to be addressed in a way that is understood at the individual and community level. Government can be daunting for our Hispanic Latino communities, even though everyone in some form or another is touched by an agency on a daily basis, making expressing needs and concerns a significant challenge. So please do continue to be the hope and support of our Hispanic Latino communities. When the COVID-19 pandemic era initiatives and funds were available, they became a baseline of essential resources to address many inequities. And now that those resources have ended, it has placed many of our communities back in a cycle of struggle. Next slide, please. For Hispanic, Latino communities and individuals, the American dream lies in the hope within our systems to allow us the opportunity to make positive generational change. It truly is the point in the pursuit of life, liberty, and happiness, the pursuit of wellness for our loved ones, families, and communities. Next slide, please. Y muchas gracias. Thank you to all of you for taking time to hear today and share the challenges faced by our Hispanic Latino populations. And a special thank you to Dr. Yanira Cruz and the NHCOA team for hosting this critical event. Y que todos tengan bonito día.
And again, thank you to our sponsors, speakers, and the attendees for joining us for today's virtual event. We encourage all of you to follow us on NHCOA's social media channels, X, formerly Twitter, Facebook, Instagram using @NHCOA, @NHCOA for more information about upcoming events. Let's continue advocating for programs and resources to better support older adults and their caregivers. Until the next one, see you soon. Thank you. Gracias.